Good afternoon, everybody. It is Wednesday, the 20th of July. You're here at Lunch and Learn. Today's topic is managing clients and patients with medical and psychiatric disorders. That was a topic that was suggested to us, and we posted for today. We're getting folks unmuted, and once we get that done, um, either Richard or I will maybe just start off with some general comments. We were discussing, right before we started, that this is an interesting topic because people have different ways of what they consider to be difficult patients, and how you would manage what would be maybe a difficult patient and one's clinical experience. So I think what I'll say to begin with is that there's no one correct answer here. People have different backgrounds, different experiences, work in different settings. Um, when I worked in a clinic, I had access to other clinicians who were making referrals to be able to talk about a particular patient. When I worked in the doctor's office, if it was the patient that was that doctor's patient, I had that doctor accessible to me basically 24/7 to get a consult and discuss things, but that's not always the case. So, well, go ahead, Richard. You can make some comments. I gave some starting ones.
Well, I think this is an interesting topic because you're kind of put in a rough position to begin with if you're a neurofeedback provider, because neurofeedback is still relatively new. I know it's been going on since the 60s when it was discovered, and 70s and 80s when it was used with Peniston and others, and then in the 90s when it was really being more widely used. It was still very small. I mean, ISNR meetings were 280, 290 people in the late 90s. I think we got them up briefly in the early 2000s to 700 or 800 with Leslie Sherlin's brilliant marketing and management, and then it kind of goes down a little bit, and the number of providers is not that high. I imagine it's 20, 25,000 in the United States at this point. It may be more. Nobody really knows. Maybe Rob has some numbers from ISNR, but you talk to somebody in the street and about about neurofeedback, and they're like, "What's that? Wow, never heard of that. That sounds cool. Can I have your number or what's your website?" Not many people ask for a business card anymore. Anyway, they look it up on their phone. Oh yeah, there you are. Because of that, people kind of discover it. They're like, "Oh my God, nothing's working," and they're surfing the internet and they discover it. And of course, they've already spent most of all their money and all their resources and been to all the doctors. And most of the acute care specialists are failing miserably at chronic care and are 20 years behind on the research literature. I have multiple publications, including citations from JAMA to support that statement. And just my own personal experience with medical doctors is I'm appalled by their lack of knowledge, except in one very narrow area, and they're extraordinarily good at that area, and that's acute care. Outside that, they just don't seem to know much. So, you have these people running around looking for a functional medicine doctor. They're really hard to find. And of course, they come into your door exhausted, at the end of their rope, depleted financially. I mean, a lot of times this is who shows up, either themselves or their child in tow. And they're going like, "Okay, I heard this might work. I'm here to," and by definition, you've got a severe case. And the fact is, the percentage of severe cases that walk in your door if you're a neurofeedback practitioner are pretty high compared to people who are moderate or mild in their symptomology and then their diagnosis. So that's a really tough place to start from. And on top of it, they usually want to know, well, can you show me some research? Well, how do I know this is going to work? Wow, there's a lot of money. I've already spent everything on all these other people. So it's from the start, you're almost on the defensive and in a tough situation with them, and they're frustrated, worried, concerned, overwhelmed, and somehow you have to turn that into a client and ultimately into a successful client. And so I think the majority of you do deal with severe cases, but maybe you don't. I'd love to hear it if you don't. If like half your clientele or 3/4 of your clientele isn't that severe. And how do we really define severe in terms of human suffering? I mean, on the pain scale that they use at the hospital, pain is qualia. That's what drives everybody nuts. They can't empirically measure it. They wish they could, but it's like the taste of chocolate. It's qualia. And you tell anybody in pain that is not pain, see what happens. You tell anybody in pain and say, oh, that pain's not so bad. Let me tell you about my pain. You want to see a nasty reaction. So everybody in medicine knows that's qualia. So how do you define the level of a person's suffering and pain to call them severe? So those are some of my issues and problems.
Yeah, and I'll tell you, one of the things as you were talking, I'm thinking about is here, and I'm going to target this right down to the just the new mind, software at this point. I'm going to just focus on the new mind maps in particular. We've encouraged people when they submit maps to make sure they also have had the patient complete and submit the physiology, have the patient complete, the CEC and the ISI, because in addition to their background data, that's information that's helpful to us. When I've worked with some of the people I mentor, if I look at their accounts, I'll say, well, this person never even filled out what their medications are. They didn't indicate anything about head injury, coffee, exercise. All that stuff is important. And so the other day, well, actually this morning I was mentoring somebody who said, I just have somebody, and they're just not overall doing well. And I said, well, there's several things we can discuss about what could cause that. And we've discussed those, here, Richard. We've talked about, physical health, substance use, whether it's prescribed medications or recreational, and then, social relationships is three factors that can negatively influence the benefits, of neurofeedback and how people train. So I showed an example of a young girl that I'm working with. She's had 11 or 12 sessions. My sense is things at home aren't terrific between her and her dad. That's the best I can gather. I've met with her and her mom, did a brain map. But her training is looking about the same. It's not excellent, not horrible. And then her progress tracker, when all is said and done, no significant improvement. And when I went to go look at, why that might be, I went back to her physiology score, and it was 180, and this is a 17-year-old. That
Wow.
is a lot of physical health problems, as we know and discuss here. And I think to myself, well, that's one reason why she may be progressing slowly, because we have this tool, and this tool that gives us a score that helps us gauge how they may do. And it makes sense over time with experience that people with a lot of physical health issues, tend to go slower. And then, of course, I always cite the example of someone who may have Lyme's disease, because as long as it's active, the neurofeedback helps. It doesn't have any staying power. They feel good for a day or two, then they're back to ground zero. You do a session, they feel good or better for a day or two, back to ground zero. There's no cumulative effect. So depending on the nature of the person and how much effort I think we as clinicians put into getting good information, and then how we use that information, helps determine whether someone's going to be a challenging client or not, just as a point of discussion.
Yeah. So those are different ways of defining
Yeah,
severity.
yeah, yeah. And, and then psychiatric meds versus medical meds. When they come in on your and dump on your desk, the Walgreens bag gets turned upside down, and 6 or 8 bottles of pills come floating out, and most of them are psychotropic meds. My first question to them is, what is your inclination or your intent? Do you want to try to get some of these meds reduced or get off of them altogether? And if they say no, for me, that's the first red flag that maybe it's not somebody I want to work with. Because if you're telling me, for example, you have depression and you're taking this antidepressant and then you're taking Abilify to help with that antidepressant and you're still depressed and you're taking these meds, um, why are you here? You
Yeah,
know, well, the meds aren't working. Okay, are you interested in going off? Oh, no, 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 I can't go off the meds. Well, then why are you here? You're
yeah,
telling me you're on meds, they're not working, but you don't want to go off of them.
that's a
Oh,
great way to deal with it.
yeah, it's an interesting way to help them understand that, we're not saying you may have to go off of all your meds altogether, but I then help them understand that it's very possible that if we don't reduce these meds over the course of time with your prescriber, that you may wind up having side effects that could get a little worse. And then the example I use for that one, Richard, is I'll say, so if you didn't have any problems with attention deficit and you didn't have any problems with focus and concentration and you started taking Ritalin, what do you think that's going to do to you? How's it going to make you feel? Well, you're going to feel jacked up. you know you're not going to feel normal.
Yeah,
And so any medication that alters brain function, which is what most of the psychotropics do, they're altering brain waves and brain function to some degree, then that's a reason to look at changing meds, reducing dosage, eliminating meds, and so forth and so on. And if they're not willing to do that, I just think it's too risky. I never want somebody walking out of the office saying that neurofeedback stuff doesn't work. That's the bottom
yeah,
line. Yeah.
definitely.
Yeah. Anyone else? Some thoughts about this? Your experiences?
Everybody appears to be tired out today.
Or it's not a topic that they're terribly interested in. We do invite other questions if it's not on this topic.
Well, then in that case, oh,
Hey, Rodney, how are you?
a new client that I'm working with, and he's doing like 4 or 5 times training a week for anxiety, depression. He's a veteran. He's got some developmental trauma, but his wife's into, she works with kids she does foster care supervision for the state, and they've adopted 3 kids. Um,
Uh,
and one of them is 10 years old, and she has fetal alcohol syndrome.
hmm,
And he's saying that she was doing fine in school, elementary school, doing great, progressing. Hits about age 8 or 9 and starts not doing so well, just not learning. And he's wondering, what do you think about? He's enjoying neurofeedback already. He's already seeing some difference. He's able to relax. He's not so hyped up, and he's been diagnosed by his wife as bipolar. I don't think he's bipolar, but anyway, he said, I don't think I'm bipolar, but she just says that because I'm moody. Well, that's probably from his veteran experience and other things, but he's recognizing differences already, and he's quite appreciative and really going to work hard at it. But he's saying, man, if it's working good for me, what do you think about my adopted daughter, my 10-year-old with fetal alcohol syndrome? I said, whoa, I'll have to ask about that. So you gave me a chance, so I asked about it. So what do you
all
think?
right.
I
Well,
know
I think,
it's not necessarily appropriate for this topic, but close enough.
well, no, it is because, again, you're dealing with a medical diagnosis or a medical condition that could put a challenge. So it fits into the conversation, whether you like it to or not, Rodney. Now we can go to a different topic or we can fit it in perfectly.
Oh, that's all right. You can go with this now that I got you on it.
Now, what I will say to
I'm
you is that I don't have experience. I've never worked with a fetal alcohol syndrome child, so I'm going to defer to Richard. But my best sense is you can still get some improvement in some areas, even with fetal alcohol syndrome, if you're doing neurofeedback. Richard?
I haven't worked directly with fetal alcohol syndrome either, and it's way underdiagnosed is one of the reasons I know. But the other reason is that I have worked with people who are working with kids, and they have gotten improvements, certainly. And there's no reason not to expect it. You know, they were saying that children with really low intelligence didn't respond to neurofeedback, but I found clinicians who've had success with that too. I think one of the problems is that, a diagnosis is an abstraction. It's not representative of everyone in the population. It's an attempt to find a Procrustean bed that you can squeeze a group of people with similar symptoms into. And they're all very different, really. And that's a huge problem for us in healthcare and just dealing with human beings. We keep trying to put them into these generalized categories, which only very loosely fit them. And I think there's probably a spectrum of fetal alcohol syndrome, just like there is with everything else in terms of severity. How much did the mother drink? What was her health? How was the delivery? How was she after the delivery? Was there depression after? Did she care for the child? They had the resources to care for the child. I mean, all of these things would determine how that child developed, plus how much trauma was there in the family, how supportive of the child were they at, or critical windows of development, and then they come to your office. And so there's a massively complex etiology and history to them that's going to make them all fundamentally different. It reminds me of that saying, if you've seen one kid with autism, you've only seen one kid with autism.
Yeah.
They're just too varied. And I've experienced that with just about every disorder. I've had people come in with Lyme and trained them and just about eliminated their symptomology and had go back to an incredibly normal life. Had other people come in with Lyme and we barely get anywhere. And the reasons are very complex, just depending on their history. But then also, as a therapist, are you able to get them to understand that they need to reduce medications, that they need to improve their diet, their sleep, that there needs to be more activity or exercise or stimulation. These are all factors that are critical to care. The idea that you can just do neurofeedback or any other intervention in the universe on anybody and expect it to always work is mythological. I mean, it's very hopeful and wonderful, but very naive.
One of the things with this girl, they adopted her when she was 18 months old. She was starved to death.
Oh, this is the girl you're talking about?
Yeah. Yeah, the daughter, the adopted daughter of my
Well,
new
when you said
client.
starved to death, I'm going like, she's alive? You mean
Oh
she was
yeah, no, I'm sorry. No, she was
severely
just
malnutrition,
yeah, gross
malnourished.
malnutrition,
Okay.
yeah, malnourished. Sorry about that. I was being dramatic. Sorry about that.
That's fine. Be dramatic if you could follow up and say, but she survived.
Tell her.
So our chicken ghost now, huh, Rodney? Yeah, it's
Yeah, right,
a lot of
exactly.
clients like that.
I'm a spiritual person.
Yes. Well, then it's not just, you're not dealing with somebody who just has fetal alcohol syndrome. Somebody has fetal alcohol syndrome and was severely malnourished as a child during key developmental periods.
Yes. Yes, makes sense.
And if that was the case, was she also abandoned emotionally? Because if you're not feeding a child, that typically means a parent that's neglecting the child, which means they're also usually neglecting them emotionally. I mean, most parents who emotionally neglect a child will at least give them food. So it sounds like there's a fair amount of abuse here or neglect.
Yeah, I would
That,
imagine that. Yeah, I would imagine if they're, if they neglected her diet, then they were certainly neglecting her emotionally. But I don't know that. It was a brief conversation.
yeah, I dig in deep on that one.
Yeah.
Because that diet's one thing, and a lot of kids can recover quite a bit, although it may affect their brain development.
Mm-hmm.
But emotional neglect is more destructive than physical abuse. And we know that from longitudinal studies.
So more than likely she had both. So
Yeah. So you're dealing with somebody with developmental trauma, both at the physiological level and this neurobehavioral, psycho-emotional. We have so many terms for these things. I could go on, but depending on which discipline you're in.
Yeah. But I was going to
Yes.
also add to that, Rodney, is when you think about kids who have been abused and neglected, especially neglected, neglect, the research shows, can often affect brain development, as Richard was saying. And what happens is certain aspects of the brain do not develop fully. They're smaller, like the hippocampus. And there's one or two other areas. I have to go back and look at my notes, but that can affect someone early on just from pure neglect, and cause changes in brain and how it develops. So it can be the change again, without good history. And sometimes when we work with kids who are adopted, you don't have the full history because the state can't get a full medical history because the kid gets put into care and parents aren't cooperative, or they've been neglectful. There's been no medical care, or gosh knows what. So it can sometimes be really, really, really challenging in that regard.
I think the adopted mother, his wife, she's like a advocate, and she works for the child care and works for judges, so she has access to all the records.
Oh, okay. Well, that's good. That's good.
So again, this is not a client of mine, but it's the new client's adopted daughter that he brought up yesterday afternoon after we were going over his progress.
Gotcha.
And he said, by the way, since I've got this unit, maybe we can use it, if it's working for me, maybe we can use it here for my daughter. And then he started telling me the story. And then I said, oh, I'll have to punt. I have no idea about fetal alcohol syndrome. I've witnessed it. A friend of mine was a doctor. His adopted stepson, had fetal alcohol syndrome, and I know it was very disruptive for the family. But I remember watching him play sports and in the front yard, but didn't have much social contact with him, so I don't really know much other than what I observed and discussed. But as far as doing neurofeedback and brain training for someone with that, I don't know.
Yeah.
But I like what you say about the hippocampus and neurogenesis and learning. That begins to make sense for me.
Yeah, and that's why I think we both would say to you, nothing ventured, nothing gained. It certainly would be worth looking at a map and getting a good complete history from the parent, so you have a sense of what happened or did not happen. I adopted two kids when they were really, really young, and they were severely abused and neglected. And fortunately, they were young enough that the physician we took them to, who was a pediatrician, said to us, right now they're underweight, undersized, under head circumference, all those standard measures that physicians do to see if kids have been abused or neglected. And we knew the whole history, and we knew there'd been neglect. So he said, but they're young enough that we can reverse this. Now, back in the 90s, you might recall, if you had kids, they were moving away from, kids being on, regular milk, and moving more towards low fat, no fat, because of the issues with kids and weight gain and all that. And he said, you're not going to pay any attention to that. He said, their brains are still developing, and you're going to give them all the fat you want. Do not cut back on dairy fat, because that's going to help them with their brain development. Now, I was living in Vermont, and so the story I tell is Ben and Jerry's ice cream factory is up there in Vermont, and they had what they call factory second outlets. So the beginning and the end runs may have had a little more cookie dough and chocolate chip cookie dough ice cream, or a little less, but they weren't consistent. So those got sold half price. So I went down, I'd go buy pints of Ben and Jerry's ice cream, and we all ate Ben and Jerry's ice cream to get all that fat in. So the only problem I created, I think they both got addicted to ice cream, but short of that, we got them back up to speed, developmentally. And my daughter's incredibly bright. Now, she didn't have fetal alcohol syndrome, nor did my son, but they both did well. And I did neurofeedback to help counter some of the other things that, we had going on with them. So I think you did fine mapping and working with this child, and usually within 5 or 10 sessions, I imagine that parent's going to notice some slight improvement with that child, and then you're on a good course. That would be my suggestion.
Okay, great. So that gives me a little impetus and a little
Yeah,
more courage to go, okay, nothing
yeah, why
ventured,
not?
nothing gained. Yeah. And they're delightful people. I'm really encouraged by him because he needs it so much. But also, the more, of course, when you get to talk to people, you immediately get into family history. Then you get
Right.
into family systems, and then you start figuring out, boy, this brain stuff, there's a whole lot more going on here that you can't see that's historical. So,
Yeah, yeah.
so
But
fascinating.
we get a
I,
little bit of a window into some of that stuff when we work with them. So sometimes we can be really, really helpful.
Oh yeah, just one yesterday talking to the mother of my only client on the autism spectrum. Is an 11-year-old that I've been working with for a year. I've worked with her older brothers, um, and her mother told me some nuances that facial expressions now. She is reacting to emotional situations more with raising her eyebrows and spontaneously reacting. And the other day, um, and she's modeling a little bit on one of her older brother's girlfriends. They were getting ready to go to the mall, and she said, just as they were walking out the door, she says, "Oh, just a second, I got to get my pouch," and it's a cross-chest strapped purse, like. So she put it on just like her older brother's girlfriend, and she was all ready to go. But she said the mom said that spontaneity, recognizing the emotions of the situation. She says it's really the first time that I've really noticed it that pronounced. And she says I have to believe that that's because of all of her training. And I got to tell you, her training sessions that I look at with this wonderful, I look at the performance and the asymmetry and um, the trend lines. I only wish that her brothers could have the same performance that she does in her brain training. It's just fascinating. So we're beginning to see the social piece begin to formulate and change, so that she's becoming more spontaneous. And our goal is that when she comes home from school, that she will have more than one sentence when you say, "Well, what did you do today?" Instead of just one little blurb, she might actually have 2 or 3 sentences to describe her day. That's kind of our goal, but she's a delight to work with. So, and neurofeedback is having a positive effect on this little brain on the autism spectrum. I just thought I'd share that.
well, that's great. And I like the fact that you included that her training screen, her trend screen. When we ask, the client says to you, will this work with my child? You don't know, you know, and even medical doctors half the time don't know, that they might have ideas of percentages of success rates. But I think when the parent says that, you have to say, well, every child is so different. It's just not reasonable to say yes, you know, but at the same time to say, well, we have success with this problem. Other clinics have had success with this problem. And if it's a really unusual syndrome, which you've never heard, and there's so many of them, and undoubtedly there'll be people showing up with syndromes you've never heard of. You say, well, you're probably safe saying, well, there's very little research on all these syndromes in neurofeedback. And you just don't know until you try. And,
Truly.
and it's the same thing with drugs. They don't try drugs out on every type of developmental disorder or every type of health problem. When a new drug comes out, they don't look at the EEG consequences of every drug. And there's a reason. One of the reasons for that is everybody has such a different response to the drug. again, developing, that depends on your genetic and developmental history.
Yeah.
Sure.
And the fact that even if you're making a little bit of progress, for some people, a slight improvement, it may seem slight to us, but for that person or the family, that's a
Yeah.
big, big, big improvement. And they're just like delighted that now she can speak 2 sentences versus 2 words. Now she can say, I would like to go to the park or whatever. I mean, that's like versus park. Well, what about the park? You're talking about parking the car or going to a park. So it's a tremendous value to those families when we can even make slight changes that make somebody a little bit more functional than they were. They may not be 100%, but we got them from 15 to 35.
Yeah.
I got to tell you this little story too. It's embarrassing for the older brothers, teenagers, 3 older brothers, quite good athletes and all, very intelligent. But she took her first plane ride to South Dakota to visit her grandparents, and when they were landing, um, she 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 likes to be happy. She wants everybody to be happy. She doesn't want any kind of conflict or anybody to be unhappy or nervous or anything. It upsets her a lot. So she likes happiness. So when they were landing the plane, very loudly, she threw her legs out in the seat and went, "Wee!" as the plane was landing. And everybody in the plane kind of turned around, and the brothers were like, "Mom!" They were so embarrassed. And
And
the
probably
mom,
everybody else was laughing.
yeah, but her mom was so happy that instead of being full of fright and fear, she was
Yeah.
just loving this sensation and willing to share it with everybody on the plane.
Good
Anyway,
one.
I'm off the
Yeah.
subject, but
Well, I think you brought up another really good point in that what, as Rob was saying, what's the definition of improvement? Every family is going to be different, like Rob said. And so I think you have to ask the client, also the patient, well, what improvements are you looking for? Oh, I want everything fixed. Well, let's get realistic. You know, you've been everywhere looking for something. You're not getting improvements enough. Have you gotten any improvements that you liked? How much? What would be the most improvement you'd be interested in? You know, I want to go to my acupuncture doc. He says, list top 3 things that you're concerned about, and how much of a change you're looking for, which I think is brilliant. Very simple, but very brilliant. It's kind of a Chinese approach.
one one of the things that I noticed, I've been to the household. I'm in South Georgia now, and they're in North Georgia, and I visited the household like 4 times to do brain maps and one thing or another. The last time I was there, we were talking, and she calls me Poppy, and so she grabbed my hand and she made direct eye contact with me to make sure we were communicating, and then wanted to take me in another room to show me a new toy that she had that she really enjoys. And she grabbed my hand and took me with her, but before she took off, she got my attention and looked me straight in the eyes and made good eye contact, and then said, "Poppy, come in here and look. I want to show you this." And she pulled me into the other room. She didn't have to pull me. I mean, I was willing to go, but I was excited that she had made eye contact. She didn't hold it for very long, literally like maybe 2 seconds, but it was enough that she looked me directly in my eyes to get my
Yeah.
attention and to connect socially, which to me meant the world.
Well,
She was doing that.
I think most parents dealing with autism of any kind would be thrilled with that, unless it was a really high functioning autistic child.
True.
Well, that's a good example of how what might seem a small event can be really of critical importance, especially when it comes to synchrony and eye contact. That's one of the big problems with autism.
Well, one of the things that I really am enjoying since I'm in Thomasville and they're in North Georgia is I can look at performance and I can see with this new software her layering, her compression, the convergence and levels, that means a lot to me to help me show literally graphically where she is improving.
Yep.
And I can share that and try to change that into functional terminology for the mother to say, yes, she is improving.
Yeah, and that's a more refined and subtle, those are more refined and subtle measures than just the gross, oh, are they within a standard deviation or have they changed their standard deviation? That's such a unidimensional perspective to try to apply to the complexity of the human brain. But when you start looking at these other dimensions, you can see more subtle changes. And I love the fact that you're looking at the trend screen to make that assessment, because really people say, well, what protocol is going to work? Or how do I know it's going to work? And you know, how do I know if it's working? And even though they're saying it's not working, is it working? I mean, it all comes down to that trend screen, which is why we make it the center of the software. And I've had to fight tooth and nail developers and UI people to maintain that. They have no concept of that. And even Brainmaster has had no concept of that. I had a lot of talks with Tom Kalura, and he had no clue. He was not even mildly interested. I said, you got to be kidding. I've been watching your software for 15 years, and you don't even notice this stuff? Of course, that's when I went off and built my own. But yeah, it is subtle and it's powerful and it's there. And when you look at those measures and relate them to the other neurometric dimensions, they deeply correlate. You know, they are empirically correlated, and they are empirical measures of change in the brain, and they're more subtle than just 1 or 2 standard deviations above or below. Because one of the problems with standardization with QEEGs is that you have a lot of people who are on the tails of the curve genetically or for other reasons. And they may change in ways that don't show up statistically. That's really apparent. But if you're using human pattern recognition and you know what to look for and you're looking at those trend lines, you can see the changes. And when they occur, when enough of them occur, you will see changes in standard deviations if you're like using Z-score training, because I used to do both.
Nice.
And I used to say, like, well, why am I looking at this gross measure when I have this fine measure, which is much better? So that's why I abandoned Z-score training. You know, plus we don't have any research to show it's superior in any way. If you like it and it appeals to you because you're technical and statistical, fine. But I think you're missing a lot of the subtle things. Now, Penny Jean Gracefire is brilliant at interpreting Z-score values. You take enough workshops from her and in enough years, I think you'll start seeing the same stuff there that you'll see in ours, but it's a long, steep curve. And I know most clinicians would much rather just have a more simple visual pattern, because as therapists, we see patterns, we hear patterns, we feel patterns. You know, we're not statistical professors or of skill. So looking at the trend screen tells you, is this working? Because it tells you, is the brain responding? And it tells you, is the brain responding consistently? Or is it starting to look good and then backsliding? Starting to look good and backsliding. If that's happening, you know, you've got to remember, and that's the hard thing to remember, it's not because of the neurofeedback, it's because something's confounding the neurofeedback. That's why I always say neurofeedback will always work unless there are confounds. That's the hard lesson of 20 years of clinical work and careful tracking. And Rob and I work together on that. And I think, you know, and some other people too. And I think, but particularly between Rob and I, we were seeing the same things in really diverse populations with a lot of other onlookers. and professionals, and it became pretty clear that it's the confounds that were getting in the way, that do get in the way. And it's not unique to neurofeedback, it's unique to, if you want to say it that way, to every other professional who has an intervention, whether it's nutritional, whether it's surgery, whether it's drugs. I mean, and particularly psychiatrists have all the same problems we have. You know, what protocol? Well, that means what medication? Well, they try a medication and they often have to go through multiple medications, sometimes for years, to find something that works for a patient. And there's not a one size fits all. I mean, they have PDRs and all this other stuff that's supposed to give them that stuff. And we have maps that are supposed to. But just because the map says, well, they have a pattern like this and this protocol usually works for this, they may have other things going on that are getting in the way. When you're looking at that trend screen, you're in the trenches and you're seeing, like, how much change am I getting? I know what I need to see in terms of subtle changes. I need to see convergence. If their amplitude's too high, then I need to see some compression. You know, if their layering is way off, I'm looking for improvements in layering. You know, the eyes open showing me delta, then theta, then alpha, beta, or something close to it. It doesn't have to be exactly that way. Is the amplitude off? You know, are they all squashed down below 8 microvolts, or do they have a nice spread up to 12? These are things that are crucial for a healthy brain, and that you watch to see subtle changes while you're training. Those are the things that tell you this protocol is working. Those are the things that are telling you that nutritional support's working. Those are the things that are telling you that extra sleep is helping, because you're looking at that trend screen and talking to them every time they show up about their behavior and their experience, if you're a good clinician. And that's why we have a symptom tracker, so you can track that. So these tools are really critical. So if you're fairly new, and sometimes even if you're just new to NewMind, that's the heart of what we do. And that's the answer to everything. What protocol to use? Try one and watch the tracker watch the trend screen. You know, is the protocol working well? Look at the trend screen. Are they changing? How much? Is there something in the way? Look at the trend screen. Are they backsliding constantly? I mean, each of these things, these questions are answered by the trend screen. Am I making good progress? Look at the trend screens. I mean, pre-post maps are great, but those trend screens really tell the story. And it takes the burden off of you and puts it on the trend screen, on the empirical fact of neurophysics. It's not what the client thinks or you think, it's what's the neurophysics telling you, what's that trend screen doing. That's unavoidably the fact.
One of the things they want to know, like new clients particularly, for instance, I have 3 clients in their 20s with various reasons for doing neurofeedback, but they want to know, do you think I'm improving? Am I getting better?
Yes.
That's really a personal question for them, but I said, following, and I send them, every one of them, I send them pictures, screenshots of trends, performance, asymmetry, activation, every time they do. I watch them every morning. I check in and send this to them. So they give them evidence, some feedback, so they can see that they're changing. And does it connote improvement? Well, let's look at your progress tracker, your symptoms, the things that you're following and how you're functioning. And you tell me if those are improving, and we see that you have a graphic expose of your changes in your brain in these trends and performance, asymmetry, etc. Put the two together, you tell me, are you improving?
Yes.
Those kind of things. So instead of it's a change, I don't like to hear. I said it's changing. I tell them, so how am I doing? Well, your brain's changing. That's a good sign. If it's not doing anything, that's not a good sign. Then we need to do something different. But if it's changing, that's a good sign. And this is where we can measure generally measure your change capacity.
I like that, Ronnie, because when you look in the pre-post map, that's the measure, and we've done thousands and thousands. Like we have hundreds of thousands of pre-post maps, and we looked at the norm. And, I don't know anybody else who's done that work. We have, and I'm going to publish that paper. I finally wrote it up earlier this year. I'm just refining. We'll publish that in my journal so anybody who wants to see can look at the statistics. But it's 35%, 38% technically is the, I always round things off, is the average percentage of change when doing neurofeedback. It's just a fact, statistical fact. And it varies between 28 and I think 42 or something like that. But that's a really good.
If I could get that in the stock market, I could retire.
Yeah, that's good. You sure could. And when people aren't doing well, I mean, it's way down in the 20s, and you can tell. And so now we have a benchmark. We have a reference point, and we can tell, overall, how much are they changing? And you can't see that in a map just by looking at it a lot of the time, because there are how many thousands of variables you have to look at all at once, all of the locations, all of the changes in standard deviation across all the neurometric dimensions. Nobody can do that. You need a statistical tool to say this is how much it's changed. And when you're seeing change in the trend screen, you're going to see that reflected in the total change in the map. That's the one thing they have in common. Amount of change in the trend versus percentage of change in the map. They're deeply related in pre-post map, which is why we use that concept.
Well, thank you. I ended up taking up the majority of this.
Oh, that's great.
It still fits right into the topic for today, though. Working with managing patients who have health or physical health or mental health issues, psychiatric issues, and things seem to fit good. And then talking about how you look at that change fits right in as well. Are we making it or not? Yeah.
Well, thank you for the feedback.
Yeah.
Oh yeah, no, it's great because we were talking about severity all the time there. How do you know? It's because it's the severe people come in and you don't know if it's going to work. So where do you go? To the trend screen. After you have the discussion of everybody's different, we won't know till we try. It's not reasonable to try to predict. That's like trying to predict the stock market. Will it work? If I buy this stock, will it still be good in the future? Well, anybody who's on Wall Street can tell you it's impossible to predict that. It is literally impossible. And nobody knows what the market's going to do. Nobody knows if a medical procedure is going to work for sure. There's a percentage that you can give them, but for you in particular, you may be in that tails of the curve. If you get a vaccination, odds are you'll be fine. But there's a tiny percentage that will have a severe reaction or maybe even die. You don't know if you're in that percent or not. There's no way, there's no way to truly predict, but there are things that help predict.
Well, in the same way that you've got with the brain, you're dealing with quantum physics, almost the same thing when you're dealing with the stock market, because it's not some professional sitting up there dictating. It is the whole market, the people, the idiosyncrasies of the people that determine almost to a quantum level when you get to the number of people participating in the stock market.
Yeah, at the rate, and same with all of the cell assemblies in the brain, through all the layers of the cortex, all, the 10 to the 10 connections, and everyone has 10 to the 14 people to call on the phone. 14,000 people to call, not 10 to 14, 14,000 people to call on the phone, every neuron. The complexity is profound, and everybody's different. And that's what drives the psychiatrist crazy. He's trying to get the right drug for the right person. So your problem is the same as theirs, and I don't think you should never feel singled out as a professional or a different, and you should go with the confidence of knowing that everybody who's a professional is going to have the same issue. They just may be overlooked or more accepted because they're the people coming in are trained to believe, that they're all knowing, that the doctor is somehow all knowing is something that people kind of fall into as a belief kind of in our system until they get older and they run into enough health problems and enough doctors. They go like, wait a second, there's a lot of crummy doctors out there who don't know what's going on, and it's hard to find a good one.
Well, you've given me encouragement too for potentially working with this gentleman with this 10-year-old adopted girl with fetal alcohol syndrome. I'm not going to be working with fetal alcohol syndrome. I'm going to be working with a 10-year-old girl.
Yes, exactly. And that's the whole point of functional medicine and functional neurofeedback. You're not working with a label. You're working with a person with a complex etiological history, and you have to understand that history to help them the best. And it's impossible to predict the outcome too specifically, but generally you can make improvements.
Well said. So thank you for the encouragement.
Well, thanks for all your input, Rodney. It's always
Yeah, and good cases as examples.
we didn't have Carl here today, so we needed Rodney.
Yeah, right. Exactly.
Yeah.
It's Carl.
Carl Theodore, he's
All
always
right. Well,
got lots of
folks,
questions. Yep.
we hit the top of the hour. We have a wide open agenda for Friday, as far as I know. So if anybody has a particular topic or wants to submit a mat, send them along. And we'll see you Friday. Until then, have a great Wednesday and rest of your week.
Yep.
Thank you.
Bye, everybody.